Hello.
Hello. Yeah.
Yes, sir. You can start whenever you want. The room is open for the attendance.
Okay. No problem. I start in 2 to 3 minutes time. I'll start.
Okay, sir.
Thank you. So I will start now. So good evening to all of you. Today I'll be starting one short case followed by 2-3 rare cases given to me by Dr. Samia. So I will show my first short case now. Is my screen visible? Is my screen?
Yes, sir.
Okay, right. So this is a story of a 52-year-old man. History comes into the right upper limb in the form of difficulty in writing for 6 weeks. No history of any micrographia. No sensory complaint. No walking difficulty. No other complaints except for its clumsiness of the right upper limb. No history of any fasciculations. Now on examination, you find that these trainers are all normal. There is labella type was absent. Ocular movement is normal. Come to the limb examination. Whether there is a spasticity or rigidity, I'm not very sure. They appeared more spastic to me rather than rigidity, but doing like this appears rigid. It's rigidity only on the right upper limb, not on the left side. Power is normal power. Extension is normal, flex is normal. Small muscles of the hands were normal. And the small muscles were all normal power. If you do the akinesia, there seems to be mild akinesia on the right side. Is it genuinely there or not? You have to decide. Lower limb, there is no spasticity, no weakness. Reflexes Georgiac was normal. The reflexes are generally brisk in both upper and lower limbs. Slightly more on the right upper limb on one in supinator. Triceps reflexes are all normal. I mean, brisk reflexes bilaterally. Knee jerk are also bilaterally brisk. Ankle jerk was normally elicited. Plantaris flexor. Abdominal reflexes were intact. Sensory system examination was normal. Is it correctly? Joints in little finger is also normal. Is it correctly? Rhombox was negative. Gait appeared normal to me. There's nothing, no definite decrease in the arm swing. Some suspicion, that's all. Okay, on examination, findings confined to the right upper limb. Rigidity or spasticity to the right upper limb. Power normal. Chronic hypokinesia to the right upper limb. DTR both upper and lower limb brisk reflexes bilaterally except angle jerks, which are normal. Sense system normal. Gait normal. So what do you think most likely site of lesion probable diagnosis in this patient from this finding?
Cervical myelopathy, sir. Asymmetrical.
Okay. Asymmetrical. But he has no, absolutely no sensory joint sensors normal in the little finger. Could be hemi-Parkinsonism.
Basal ganglion circuit, sir.
Pardon?
Left basal ganglion circuit.
Like duration is little long, not acute. 2 weeks duration, 2 to 3 weeks duration.
The infarct or something in the basal ganglion, left side.
Okay. Stroke possibility. Yes. Anything else? Okay. Why not Parkinsonism on the right side? You're not happy to diagnose Parkinson's disease? Okay, what investigation you want?
MRI brains.
MRI brain. This is MRI brain. Normal. What else you want now?
Cervical spine MRI.
Okay. In fact, patient was already put on Syndopa plus from elsewhere, which did not result in a significant improvement. So, you want EMG to be done for this patient? Because he has absolutely no sensory, only pure spasticity without any much weakness. Okay, EMG was done, which is normal. What else you need? Cervical spine. Okay, this is cervical spine. You should have compression at C3, C4, compressing in the cord anteriorly and posteriorly. This is the culprit lesion between C3 and C4. No, because this presentation was quite odd, because initially was thought to have pyramidal lesion from a neurologist, sorry, Parkinsonism, because one cannot find fault with that diagnosis because he was something like hypokinesia on the right side. He has no sensory at all, no pain at all, to think of a cervical myelopathy. So I also thought could be, I thought pyramidal lesion because of, and I thought it was more spastic than rigidity. And I thought motor neuron disease as the first possibility because he has got pure sensory reflexive brisk, no weakness but spasticity. So I thought that's one possibility I thought initially. So I did an EMG first. EMG did not show any fasciculation. Then I went for a cervical spine. That is why I showed the disc. It's uncommon presentation, but sometimes you can present only a spasticity without any weakness in this patient. Usually in pyramidal lesion bodies and compression, you expect some degree of weakness. But that is why the previous doctor thought could be Parkinson's because there's no weakness, but slowness in activity and stiffness. Okay, that's all. It's a short case. You made a diagnosis correctly. Okay, right. So shall I go to the next case? Any questions in that case? Okay. So these three subsequent cases are from Dr. Samia. He had gained at various times. All are rare cases, not that common cases. And the cases there's only short history because I have not examined the patient. Whatever history I'm telling you is the history given by Dr. Samia. History of severe intellectual disability, slowness in the 17-year-old male, slowness in walking, and abnormal movements of the body and limbs for the last 10 years. Symptoms are insidious in onset and gradually progressive. His symptoms started in the form of, at the age of 7 years, in the form of frequent unprotected falls due to stiffness and tripping during walking at 7 years of age, along with steady decline in the scholastic performance. Later, there were also backward falls, which ultimately progressed to severe postural instability, preventing the patient to sit on the bed. He had no history such to any perinatal asphyxia or developmental regression. He has a maternal cousin who suffers from a similar illness. So intellectual disability, first to start with recurrent falls and severe postural imbalance, tended to go backward even while sitting, and has got abnormal posturing of the limbs, and then poor scholastic performance. So these are the story. So only video is a short video, whatever is available, I will show.
Okay.
This is the patient. He has got some arrhythmic
দুটো
movements of
হাতকে
the
দূরে
limbs.
দূরে রাখো, একসাথে রেখো না।
Look at his jaw is open, so keep it open. And there is movements of the jaw up and down and protrusion of the tongue in between. And the forehead also goes.
ঠিক আছে, একটু হাতগুলো,
This is a movement he demonstrates in the neck. Look at the tongue, it comes
হাতগুলো
out in
হাতটা
between
হাতটা
and
সোজা
open
করে
the
দাও।
jaw.
এই হাতটা তুমি
He
উঠে বলো।
cannot lie down because of the severe rigidity in the trunk or dystonia of the trunk. So I'll show the video once again.
Okay.
These are rhythmic hand movements.
দুটো হাতকে দূরে দূরে রাখো, একসাথে রেখো না।
Frequent episodic wrinkling of the forehead upward and repeated opening of the jaw with tongue protrusion and episodic neck deviation to the up and to the right side.
হাতগুলো হাতটা সোজা
And
করে দাও বাবা।
rigidity of upper and lower limb
তুমি
and
উঠে বলো।
truncal dystonia.
Okay.
So what are your findings in this patient examination? Put a jaw opening and tongue protrusion dystonia, put neck dystonia, choric movements of the fingers, truncal dystonia, and severe bradykinesia. These are the findings of this patient with poor scholastic performance. So what are the clinical possibilities in this patient? There is a family history in maternal cousin also.
Sir, is there any clinically calf ring is there?
No calf ring clinically.
No calf ring.
No calf ring.
Okay. A history of any birth anoxia, hypoxia?
No, there's no, that's already told. There was no history of any birth asphyxia or anything. And the symptoms are gradually progressing from the age of 7 years. Up to the age of 7, he was all right.
Is there any difficulty in feeding, sir?
Difficulty in?
Feeding dystonia like that, is there any difficulty?
No, from the history, available history, it was not there. But you can see that sometime coming out.
Cognitive decline, the Westphal variety of Huntington, is there any family history?
Family history is not autosomal dominant, it's maternal cousin is affected. The parents are
Maternal.
that's it, yeah, not autosomal dominant inheritance. If at all, it could be autosomal recessive only.
First, you have to include treatable, sir. Wilson's is the first possibility, sir.
Yeah, correct. But that's the first thing we should consider. So,
Second could be a dystonia plus syndrome, sir. Dystonia plus syndromes.
dystonia plus symptoms. What symptoms you have to keep in mind apart from Wilson disease, which can present with progressive dystonia, scholastic
NBIA is
performance,
also, sir.
NBIA, very good. Okay, and we can also keep possibilities like, for example, NPC, dystonic liposis, the possibility, which can present as dystonia and scholastic performance, mitochondrial diseases. This all can present like that, dystonia and scholastic performance. And choriocondylocyte is also another possibility. We've got some tongue protrusion coming out. So the possibilities for one is Wilson disease, as you correctly said, that that's the most treatable thing always you have to keep in mind. And NBS, especially PANG2, then NCL, neuronal cerebral lipofuscinosis, juvenile Huntington's, as you were telling, and neuroacanthocytosis because his tongue is coming in and out, some kind of something like a feeding dystonia, and some lysosomal storage disease like Niemann-Pick or GM1, GM2 gangliosidosis. So these are the possibilities. So it is hard to remember the clinical features of all these conditions, but common things you can keep. Wilson NBA is one. Juvenile Huntington's has to be kept, and neuroacanthocyte has to be kept. So other findings is KF ring is negative. And this is the fundus. Fundus shows retinitis pigmentosa. Now, what all things you will keep in mind with this finding in the mind? It's got a dystonic syndrome, the poor scholastic performance, and RP.
Mitochondrial.
Okay, very good. Mitochondrialism.
Mitochondrial come first, sir.
Then
Okay. But the PANG2 also has got retinitis pigmentosa. That is NBIA PANG2. That is
Yes,
former.
NBIA pen 2 can come, and also we'll take up the Tay-Sachs in our mind also.
Tay-Sachs usually produce
Produces hypotonia, yes, sir. Not like such of dystonia, but then more of an hypotonic.
Right. So the possibilities in the NBA, there are two conditions which can produce retinitis pigmentosa, PKN and MPN. Yeah, pardon?
Sir, can you show the fundus, sir? Where is the retinitis?
Yeah, please. Yeah. This is the pigmentation you can see in the background of the retina, black. This is not the classical bone corpuscle like pigmentation you see in the classical RP. Especially in mitochondrial disease, you only find this kind of a picture. We call it the salt and pepper appearance, some black and white spots in between. Or you won't find the classical bone spicule like RP in mitochondrial disease. So mitochondrial, is one. So what you can get in RP, when you get RP and dystonia, you keep the possibility of PKN as a first possibility. MBN also can produce, which I did not know interest produce, only literature came with information. NCL is another condition which can produce retinal degeneration. But NCL can produce blindness, extrapyramidal movement disorders, and dementia. But characteristically, they got myoclonic epilepsy. It's one type of progressive myoclonic epilepsy, but that was not there in this particular patient. And mitochondrial disease, adult onset Leigh disease is another which can. So, what investigation you need now?
MRI brain.
Serum lactate.
Okay, serum lactate, MRI brain. This is the MRI brain, which is very diagnostic in this patient. You find the cerebellar atrophy there. But see, it's got a T2 hypointensity in the substantia nigra. In the medial, in the globus pallidus. Upper part normal. This is a coronal cut, again showing the hypointensity in the medial globus pallidus and the substantia nigra, which you can see here. Again, you can find out the globus pallidus medial part as well as the substantia nigra, T2 hypointensity. This is surgical cut again showing that happens in the basal in the globus pallidus. This is a T1 which is nothing contributory except for the cerebellar atrophy a little bit. Flare again shows the hypointensity in the globus pallidus. And this is one finding which is very typical here. This is the SWA sequence which shows this finding. Something peculiarity there in the globus pallidus in this patient.
So it's M10, so brush.
Very, very good. Perfectly right. What made you think it's MPAN?
So that brush signs,
Brush sign as well as the here is something
cerebellar
you
in the
find
previous pictures.
yeah, correct. The previous with this brush sign, but characteristically this is the one. What does it show? There is a hyperintensity in the internal medullary lamina between the inner and outer portion of the globus pallidus. I will show the pictures later on. This is a brush sign. It's not very typical, but I will show the original picture later on. So serum ferritin is normal, MPAN. And what is the characteristic imaging feature? The sparing of the medullary lamina in between the globus pallidus intern and external. And second is the so-called brush sign, it is a comb sign. So this is a sparing between the internal and external medullary lamina. See that area, white band between the two parts of the globus pallidus. This is another, this is not my from the outpatient. This is from the literature. Again, showing the classical appearance of this hyperintensity in the internal medullary lamina. This is said very typical of MPAN type of NBIA. This is the comb sign. Comb sign is the substantia nigra shows streaky anterior border of the substantia nigra with brush-like linear hypointensity extending anteriorly to the cerebral peduncle. In this patient, it's not very typical. You can imagine and you can find brush sign is there. But from the literature, you can make. This is from the literature. This shows the streaky. This is the one which is streaky anterior border of the substantia nigra extending onto the crus cerebri, like this. This is another picture. Again, you can find the projection into the substantia nigra here. This is again from the literature only. I'm showing some findings here. This is one. Okay, so that's about that particular case of NBIA. It's not very common, but once I will, it's better to know this condition exists. Some subsequently, I will show some characteristic MRI findings which help you to arrive at the type of NBIA in such patients. So, any questions in that case before I go to the next one?
No, sir.
Okay, I'll go to the another one. This is again from Samia. There is no video available here. This is a 36-year-old lady. This is older than the previous one. The previous patient was only 17 years or so. Here, 36-year-old. It was a young onset tremor dominant Parkinson's disease. He is instantly detected to be diabetic at the age of 36 years. And this is the MRI. I'll show the MRI, very characteristic. Tell me what its diagnosis is. You can find the flare T2 shows hypointensity in the dentate nucleus here. Very prominent hypointensity. It's also hyperintensity is seen in the red nucleus and substantia nigra. Also seen in the thalamus, globus pallidus, as well as putamen. Some hyperintensity in a putamen is there, and some hyperintensity in the subcortical white matter is also seen here on the cut on the right side. This is again T2 coronal, showing the hypointensity in the structures mentioned. Thalamus and caudate, as well as the putamen. That's a basal, that is a dentate nucleus. Diffusion is non-contributory. GRE shows the classical picture of again hypointensity in the dentate. It's also seen in the subcortical white matter. Also, there is blackish, blooming seen due to the deposition of iron. You can see it in the putamen, caudate nucleus, thalamus, subcortical white matter. T1 is non-contributory. Flare again show the same thing. So what is the diagnosis now?
So the aceruloplasminemia, sir.
Very good. Perfect. I think you are an expert in NBIAs. Yeah? What are the clues? Is an older age group. You get NBIA in older age group to think of two conditions. One is aceruloplasminemia, the other is neuroferritinopathy. The second T2 ethnicity in all the things. See, the other things, if substantia nigra or the globus pallidus, aceruloplasminemia is one condition where it affects all the nuclei. All the basal ganglia, thalamus, substantia nigra, red nucleus, and dentate nucleus. And third feature is the diabetes mellitus. This aeroceruloplasminemia can also have retinitis pigmentosa. So what test you need?
Ceruloplasmin levels.
Right. And serum ferritin. In neuroferritinopathy, it is other way around. In aceruloplasminemia, if ceruloplasminemia is low, ferritin is very high. In neuroferritinopathy, serum ferritin is very low, just opposite of what you get in aeroceruloplasminemia. Think of the opposite in neuroferritinopathy. Neuroferritinopathy, serum ferritin is low. Yes, serum ferritin is very high. Ceruloplasmin is low. Ceruloplasmin is 0.5. Ferritin is, see the ferritin, 2040. That is a serum ferritin. And ceruloplasmin is 0.5. 24 urine copper is elevated. Ferritin is upper limit of serum ferritin is 300 micrometer. Here it is 2040. Ceruloplasminemia, and it is proved by subsequently genetic test. Okay. So what is there are some clues to diagnose and identify NBIA syndromes. These are the clues. In PKN, you find retinitis pigmentosa. These are clinical clues, not radiological. Radiological clues I will tell later on. In RP and optic atrophy, if you find, the first possibility to think of PKN, apart from the MRI features I will come later. In plan or the PLA, G62 type of neuroferritinopathy, you get early optic atrophy, Parkinsonism, and early dyskinesia with drug-induced dyskinesia. So dystonia Parkinsonism type, that is part 2 G6 deficiency, that is plan. Then MPAN, which already shown earlier, they can clinically, that clue is the motor axonal neuropathy, which our patient, whether it is present or not, is difficult to check because we have not done that. But RP can occur just like PKN. FAN, spastic paraplegia, is a presentation. BPAN is that is a BPAN, that is a beta propeller associated neurodegeneration, slowly progressive from early childhood, previously called as the SENDA, that is static encephalopathy with the next other full form I forgot, static encephalopathy with the neuronal degeneration or something like that. Then Kupffer-Jakob disease, other NBIA, they present supranuclear case palsy and FFF, that is a facial fossil finger myoclonus. COSI-associated DNA NBIA, characteristic defined is oromandibular dystonia. Neuroferritinopathy is autosomal dominant inheritance. Among these, the one which is autosomal dominant inheritance is the only one is the neuroferritinopathy. All others are autosomal recessive. And neuroferritin mimics Huntington disease, old age group. But dementia is late in neuroferritinopathy, unlike Huntington disease. Aceruloplasminemia, RP, diabetes, and older age group. Woodhouse-Sakati syndrome, they got endocrine and manifestations, hypogonadism, alopecia, and diabetes. These are the clinical clues by which you suspect which type of NBIA the patient belongs to. Now, some characteristic MRI, this is all from the literature only. I made it for understanding. The findings are almost all of them have got hypointensity in the globus pallidus substitution diagram. So this is the classical PKN. You find the eye of tiger appearance. You find hyperintensity within the hypointensity in the globus pallidus. This is the PLIN, the Plateau J6 deficiency. Here you remember that some of these cases may not have iron accumulation at all. Plateau G, but there are some other characteristic finding in Plateau J6. One is the claval hypertrophy. Claval hypertrophy, this one, that portion of the medulla is very prominent in Plateau plan or Plateau J6 deficiency. Then second is a cerebellar atrophy. These people can present with cerebellar signs to begin with, or cerebellar may not be present initially, but still they can have cerebellar atrophy. And third finding is the vertically oriented corpus callosum. Again, you can find out that thin corpus vertically oriented. These are the characteristic findings you find in plan. Then BPAN is again so the very characteristic MRI appearance. The findings are in the globus pallidus substantial nigra. This shows a dense hypointensity in the substantial nigra and the globus pallidus, but more density in substantial nigra. But that is not the characteristic finding. The characteristic finding is going to tell later on that this one. That is called the halo sign in BPAN. Halo sign in T1. This is, remember, T1. T1 you find hyperintensity with a streak of hypointensity in T1. That is said to be very typical of BPAN. That is the substantial nigra halo sign. In addition, BPAN, they can have cortical atrophy as well, mild cortical atrophy. Then in the case of FAN, that fatty acid hydroxylase associated neurodegeneration, you can have iron pigmentation in the basal ganglia, but there is nothing peculiar in this condition compared to other things. Difficult to differentiate with the MRI finding alone. And there is more iron accumulation in the globus pallidus, but that is not going to help us in any way. And the one finding they find, they convert hyperintensity in the subcortical white matter in the case of man. Some clown fluid hyperintensity in the white matter may be observed. Cerebellar and pontocerebellar atrophy along with thinning of the corpus callosum are also commonly seen in individuals with FAN. Then coming to Kupffer-Apgar disease, it's more of clinical diagnosis rather than MRI finding. MRI showed hyperintensity NBIA pattern, but not specific. But it not be present in all the cases and may even appear later in the course of illness. One of the MRI findings, which is the characteristic of Kupffer-Apgar, is look at the pyramids in the brainstem. That's a medulla. Just like the tadpole sign in adult onset Alexander's disease. They can have progressive atrophy of the pyramids, resulting in decrease in the total size of the brainstem. You can see that one. Then, in the case of neuroretinopathy, just like aceruloplasminemia, here also you can have extensive iron deposition, the basal ganglia, thalamus, etc. But the characteristic finding is the cavitation. There is cavitation is seen, which is not seen in aceruloplasminemia. So over time, cystic cavitation of the brain develop in neuroretinopathy. They can have mild cerebral and cerebellar atrophy. This is aceruloplasminemia, which I already shown you before. Hyperintensity in multiple various nuclei, globus pallidus, putamen, chordate, dentate, etc. Some confluent hyperintensity in the white matter can also be observed, as you can see there. And cerebellar atrophy may be present. And MRI of the abdomen would show hypointensity darkness indicating iron accumulation in the liver. So Woodhouse-Sakati syndrome is rather than the pigmentary change, more important is the white matter hyperintensity in the flare and T2. That is the one which is suggesting of Woodhouse-Sakati if you suspect an NBIA. Copan, this is again another condition, and accumulation central region of hyperintensity in the globus pallidus. But there can be hypointensity that is due to the calcium deposit and not due to the gliosis as you see in PKN. The combination of dark region with the bright center appears to create an eye of the tiger inside the PKN, but that brightness is due to the calcification rather than due to the gliosis. Another finding is that in player, you can see T2, you may find that hyperintensity in the and swelling of the caudate nucleus. So that's about the radiological characteristics of NBIA. So this is the picture again. So the eye of the tiger appearance is not pathognomonic of PKN that can be seen in hormonal intoxication, can be seen in neuroferritinopathy, can be in MPAN. Wilson disease also can produce that thing, multisystem atrophy. And in healthy adults also it is described this eye of the tiger. So just seeing eye of the tiger is don't jump into the conclusion this is always PKN. So I will show one more case before we go to the discussion. This is again given to me by Samia. The 31-year-old male, he presented with bilateral upper limb mild tremulousness and this oro-facial movement semiology. Duration, I don't remember, it's not given to me. But anyway, more important is the clinical picture. Mainly oro-facial movements and upper limb mild tremulousness of the body. No Parkinsonism or cerebellar findings on examination. Mild cognitive decline in the form of reduced attention, information processing speed. Ocular movements normal, gait is normal. So look at the video of the patient.
চোখটা বন্ধ করো, হালকা করে বন্ধ করো, হালকা করে বন্ধ করো,
Recurrent upward
বন্ধ
wrinkling
করে
of the
রাখো,
forehead.
হালকা
Look at the
করে
face
বন্ধ
now.
করে রাখো,
Now
হালকা
lower
করে
face also episodically.
বন্ধ করে রাখো, হালকা করে। খুলো না কিন্তু, হ্যাঁ, হালকা করে বন্ধ করে রাখো।
See the wrinkling on the forehead recurrently occurring. It's also could be first person come in between.
হ্যাঁ করো।
See the blepharospasm
নর্মাল
also
করো,
in between.
মুখটাকে নর্মাল।
And look at the face,
এই
lower part
করো,
of the
দাঁতটা
face.
দেখাও, করে রাখো, বড় করে দাঁতটা দেখাও, বড় করে দেখিয়ে রাখো দাঁতটা।
Some days the
দেখিয়ে রাখো,
face
দাঁতটা
goes into
দেখিয়ে রাখো,
abnormal twitching movements like that.
করে রাখো, হ্যাঁ, সোজা তাকাও আমার দিকে। আচ্ছা, মাথাটা না নাড়িয়ে ডান দিকে তাকাও তো, বাঁ দিকে তাকাও, ওপরে তাকাও, নিচে তাকাও। আচ্ছা, আবার চোখটা বন্ধ করো একটু, হালকা করে, হালকা করে।
Look at the eyebrows going up and down and the blepharospasm. And sometimes you can find the facial twitchings also. So this is the movement of the hand. Some tremulousness movement of the hand can be also be seen, but not very gross.
সোজা তাকাও ক্যামেরাটার দিকে। একটু হালকা করে হাঁ করো তো। মুখটা বন্ধ করো।
Okay, so here, unlike the other NBA, this also I'll show the findings now. What you observed was repetitive elevation of the eyebrows due to frontalis contraction. Looks more like to be dystonia to me. Blepharospasm is there. In between, occasional lower facial stereotyped movements of the grimacing and elevation of the upper lips. Bilateral postal number. So whether again Wilson disease, NBIA, hyperparathyroidism, autoimmune disease, these are the things which you have to keep in mind. Now this is the MRI. Again showing hypointensity in the globus pallidus. See that hypointensity closer. So this is another MBA. So unique hypointensity, albeit do not think there is always to iron accumulation. Even calcification can also produce hypointensity as well as manganese. So when you can always get a CT to rule out calcification because FAST syndrome can present like that. and always ask for T1 weighted images for because ruling out manganese intoxication. Now look at the one which is condition which is producing this oro-facial kinase is the COSI. That is the COSI protein associated neurodegeneration that produces automanuals. We could not prove it by genetically because the patient was not able to do the genetic testing. From the clinical features, it appears that it's likely to be a COSI protein associated NBIA, but we cannot be 100% certain what it is. So, so we have shown 3 cases, all cases from Dr. Samia, one of empire, the other with aceruloplasminemia, other possibly COSI associated NBIA. Look at the clinical picture. So this is the clinical picture in the literature. So that's all. So any questions in that?
Sir, that forehead movements, can we think that as a forehead chorea, sir?
Which one in the facial
Last,
patient? The last no. In Korea, the movements are not stereotyped. You cannot predict one movement from another. Here it is repetitive movements. The movements are the same thing. The patterned movements. The eyebrows are going up like that. But the movement is patterned. In the other one also, eye blinking also is patterned. The 2 important characteristics of dystonia is the patterned and repetitive movement. And sometimes it may be sustained also. It's more likely to be a dystonia than a choric movement. Choric movement is random, unpredictable type of movement. Okay, any questions?
Sir, can this be eyelid opening apraxia?
If you look at the video alone, it may appear that eyeliding apraxia. In eyeliding apraxia, here you find the contraction, episodic contraction of the frontal is upward. In eyelid opening apraxia, patient is unable, his eye is closed, unable to open the eyelid, so try to keep it elevated, not like a rhythmic movement like that. Okay, I'll show that video once again. See, look at the wrinkling of the forehead.
চোখটা বন্ধ করো, হালকা করে বন্ধ করো, হালকা করে হালকা করে বন্ধ করো,
In between it goes up and down.
বন্ধ করে রাখো,
And sometimes remain
হালকা
elevated.
করে বন্ধ করে রাখো, হালকা করে
See that
বন্ধ করে রাখো, হালকা করে।
pitching type of movements. Here, in the case of eyelid apraxia,
খুলো না কিন্তু,
keep it like
হালকা
that,
করে বন্ধ
it
করে
will
রাখো।
open. It will not go up and down. It will go on trying to keep the eyelids elevated that in the situation. I don't know whether you understood or not. Or else I will show you another video on that. Did you understand what I said? That is, here is going
আচ্ছা নর্মাল করো মুখটাকে, নর্মাল।
eyelid apraxia.
আচ্ছা এই করো, দাঁতটা দেখাও, করে রাখো।
I'll show you what eyelid apraxia will be. Look at my eyes. It'll be I cannot open the eyes. So what will happen? And then opening. That is eyelid apraxia. But here it goes like that. Episodic eyebrows goes upward. That is how the difference between eyelid apraxia. Yeah, have you understood what I said?
Yes, sir. Yes.
Yes. The other is trying to open it but not open it. It's not episodic contraction. Here is episodic contraction.
Okay, sir. Okay, sir.
Okay. Any other questions? Okay, now I'll go to another case. So it's not a long case, it's a short case. This week I could not get a very challenging cases. This is a story of a 36-year-old male. 3 weeks back, he was admitted under gastroenterology department for acute pancreatitis and was treated and patient improved. 1 week after discharge, that is for the last 1 week, he noticed change in the voice and occasional choking while taking fluids and difficulty in climbing up and down the stairs. No nasal regurgitation, no headache or fever, no sensory complaints. So going back to the history, he was apparently already till 3 weeks back, 3 weeks back, he was admitted in the gastroenterology for acute pancreatitis, and there he was admitted there for 2 weeks or so. Then he's discharged, that is 1 week, for the last 1 week. Sorry, 1 week after the discharge, that is for the last 1 week. He discharged for 2 weeks back. 1 week after the discharge, he noticed change in the voice and occasional choking while taking fluids, and difficulty in climbing up and down the stairs. Look at the video of the patient. Cochlear movements are all normal. Facial movement is normal. Parietal movement is normal. Normal parietal movement. Tongue movement is normal. But his voice is husky, very markedly hypophonic speech. Ask him to count. You can't even hear the voice because it's very hypophonic speech. Mild neck weakness. His neck is quite mildly weak. Upper limb, other muscles, deltoid, biceps, triceps are all normal. Mild hand grip, very mild hand grip. I'm not very sure, but I can overcome that. So must be mild hand grip is weak. But checking the individual small muscles were appeared normal. Lower limb tone was normal. But hip flexor is grossly weak. He cannot keep it against gravity. Lift up against his knee extension is also weak. He could not do that against gravity. It comes down. However, dorsiflexion of the ankle were normal power in the dorsiflexus. AHL is also normal. Plantar flexion normal. Flexor pollicis hallucis longus normal. Abductor was normal abduction power, good power. But the adduction was grossly weak. I can easily overcome the adduction. Individually check also it is weak. I check the abduction is quite normal. Knee flexion was mildly weak. I can overcome that knee flexion. Hip extension was good power. There's a good power with the hip extension. PV sign was negative. He could not get up from the bed in the lying down position by putting pressure on the thigh. He could flex the neck but could not get up. The upper limb biceps nipples is normal. Triceps also normal, just little, still elicitable normally. Knee jakes were absent. He was putting it in a pan, difficult to see the movement, but there's no movement could be contract could be seen. Angle jakes are really elicitable. Plantar was flexor. Check the knee again. That seems to be absent. The sensation is normal.
ഒരു കിരീടം തോന്നുന്നില്ലേ ഇപ്പോൾ ഉണ്ടോ ഇപ്പോഴോ ഇപ്പോഴോ ഇപ്പോഴോ
Joint sense was also normal.
ഇപ്പോഴേ
Vibration also normal.
ഇപ്പോഴേ
Seems to be mild wasting. I'm not very sure he's putting a wearing a pen, but appear to be mild wasting of the thigh. So these are the findings in this patient. He had hoarse hypophonic voice, extravocal movements normal, parietal movements normal, rest of the canine is normal. Sorry. Motor system, mild wasting of both thighs. Tone normal in both upper and lower limb. Very mild weakness of neck flexes. Upper limbs, power normal all muscles except for mild hand grip weakness. Lower limb weakness of significant weakness of both hip flexes, knee extensors, knee flexes, and hip adductors. Hip abduction, extensors appeared normal. So also those flexes, plantar flexes, EHL, FHL are all normal. DTR, all reflexes are normally elicited in the upper limb. Lower limb, both knee jacks are absent. Ankle jacks normal. Plantar flexor, sense system normal. No thigh tenderness. Beaver sign negative. However, he could not get up from the bed in the supine position. So this is the story. So where is the localization? What's likely to happen? Any clarification you can ask me in this question.
Radicular neuropathy is one possibility, sir.
Okay, very good.
There is patchy involvement. The pharynx and vocal cord may be involved, sir. Upper
mainly vocal cord, mild involvement of pharynx also what is said is correct, but palate is paired.
And lower limb, the L1 to L3 radicular may be involved, sir. Roots.
L1, but only okay, L2, 3, 4, that is the hip flexion, L1 to L4. That can explain your hip flexion weakness, adduction weakness, and knee extension weakness. But the problem is knee flexion is also weak. Hip flexion is normal, but knee flexion was weak.
Maybe plexor radicular.
Pardon?
Plexor radiculopathy, plexus involvement with root involvement.
Okay. Like we not necessarily think of a root in this patient because you can explain by a plexus, it's okay. Some patchy involvement is that is why. See, difficult to explain little bit. So you cannot fit in with the nerve also because such a severe degree of hoarseness of voice. And he has no problem of nasal irritation. Palate is perfectly moving. The lesion has to be in the tendon distal to the supply of the pharyngeal branches. And if you think of hip flexion weakness, knee flexion weakness, it is supplied by the sciatic nerve, supplied by the face and root involvement. But other muscles supply root is not affected. Other muscles by the sciatic nerve is also not affected.
Muscle possible.
Muscle.
One possible myopathy is possible. But myopathy presenting as hoarseness again, it's little only on 1 week duration. Still, something like a myasthenia is a possibility. Because rapid onset, that's a possibility. But the odd thing is, you see, it seems to mildly wasting. I'm not sure because he was wearing a pant, but that's a little odd for a myasthenia. But otherwise, myasthenia can be considered because it is not.
Myasthenia produce a patchy muscle involvement in the lower limb, sir.
Yeah, it can produce because it's not myasthenia is not respecting any nerve or a root. It can only produce selective involvement of certain muscles. That is, say, for example, if you take a jaw muscle, you can have the jaw, the problem in closing the jaw may be affected, opening may be intact. Sometimes they come to you with the thumb behind that because the jaw will droop. Other something the clenching will be intact. Okay, so that means both muscles are supplied by the fifth nerve, but only one group of muscle is affected within the nerve. That when you get that kind of pattern, think of something like a myasthenia.
In this patient, the knee reflexes are absent, no, sir. That is against myasthenia.
Exactly. Two things are against. Knee reflex is absent is against. Then wasting is also against. And I am thinking the various possibilities. You're not fitting with the nerve only. That's your point is well taken. So, what do you want to do now? What investigation? Pardon?
Narrow conduction.
Nerve conduction. Okay. So the laryngologist consulted. See, they detected left vocal cord palsy. In fact, right was also affected partially. And left thyropharyngeus is not moving, right is moving. That is they found out, the laryngoscopy. So the blood picture, everything was normal. I'll skip that thing. NCS. Okay, this is NCS finding. Peroneal, tibial, nerve conduction, motor conduction normal, velocity normal. Then upper limb, median, ulnar normal. Sensory conduction normal. Then FA latency normal. So how does it help you in arriving at the diagnosis? What will you do now?
CPK, sir.
Okay, you can do the CPK. CPK is normal. Then
EMG.
H reflex, H reflex.
okay, H reflex. Problem is that H reflex is for which nerve? For the tibial nerve, S1 root. Here, that muscle is paired.
Knee flexion is involved, no, sir? Or
EMG, sir.
Knee flexion is involved, but the plantar plexus is not involved.
we have to look for any root involvement, no, sir? So H reflex we have to do to exclude any root or radicals involvement.
That's a problem, no? If you can, so when you do H reflex, because when you suspect an S1 root involvement, okay? But the plantar plexus are separated by the S1 is paired. You are picking up potential from the soleus. That is paired. You understood what I said?
Yes, sir. Yes, sir.
Yeah, right. So that is not. So actually, what I should have done in this patient is that I should have contracted the affected muscle. That, for example, in the affected muscle be in the here, the femoral should have been done. But femoral contraction very often, even is affected, very difficult to get. Frankly, very difficult to get. And you can't get a contraction for the iliopsoas muscle because they're separated directly from the anterior root of the spinal nerves. Then you can't do a contraction of the obturated nerve. Adductors are also weak. So those nerves are not routinely done for a conduction. So we are not very mind that. So whatever nerves which are done, routinely done, are not affected in this patient. So the normal nerve conduction does not exclude a nerve involvement or a root involved. Nerve conduction may or may not help. So that does not help to rule out a radiculopathy or a nerve involvement. Because we are not doing with the affected muscles. You understood? Because the muscle affected is not the one which is routinely done. Where NCS is not routinely done. So what will you do now? Patient is there in the ICU, this problem, what will you do?
CSF and repeat nerve conduction, sir.
Okay, NCS now. Now could it be myasthenia? The points already said very unlikely, but just for completion's sake, I did the RNS because RNS is also negative. Then what do you want? CSF? Okay, CSF was done. One cell, 1428, sugar 54. Then what do you want now? What will you do?
Sir, MRI of the muscles of the legs.
EMG,
No,
sir.
EMG, sir.
What is the point in doing EMG is what? A differential myopathy or anticonceptive disease here, what? We know it's affecting the nerve.
Sensory is not there, no, sir. Can we?
Pardon? Pardon?
Sensory symptoms or sensory signs are not there.
Correct. Sensory symptoms are not there in this patient. Perfectly right.
So can we differentiate it between a nerve or a muscle through EMG?
Okay, you can do the EMG to find out a nerve involvement versus muscle involvement. That way you can do that. So only remember there's only 1 week duration in this patient. Even nerve involvement also, you may not pick up anything in the EMG.
So there is a definite compartmental involvement of muscles. So can MRI of the muscles help?
How can it help? You can show hyperintensity, whether it is a nerve or muscle also, will show that. See, we know clinically, we know definitely these are the muscles affected. Because undoubted findings.
Treat and repeat the NCS after 2 to 3 days, sir.
No, I think here you have to go logically. So this it's most likely to be a radicular neuropathy, something like an Amman variant. In Amman, you won't find anything. See, you won't find any sensory potential. The CMAP amplitude will be decreased, but provided only in those nerves which are tested, which are affected. Here, the affected muscle is quadriceps and adductors. Okay, you can do an EMG to find out denervation. Okay, that's a good thing to confirm it is okay. Differentiate muscle, it is okay. But do you think a muscle disease person like this kind of a pattern? Acutely sparing all of the muscles, selective involvement, hyperabduction is also normal. If you look at the pattern, it fits in with the multiple nerve pattern. Because reflexes are weak, annexations are weak. That's just femoral neuropathy and operated nerve involvement. So that's a point. Little difficult, really tricky thing in this patient. CPK was normal. So what will you do? Treat it as a case of GBS?
Yes, sir.
Yeah, that is what we did. Surveyor was given a plasmapheresis for 5 days. No improvement.
So repeat the nerve conduction now.
You can do the proximal conduction, femoral conduction too. Okay, subsequently, after that, this thing, we were given IVMB for 5 days. After steroids, he started. Whether it is secondary to the delayed effect of the plasmapheresis, I do not know. But initially, for 1 week after the plasmapheresis, absolutely no improvement. Usually, plasmapheresis, even some improvement with that. I do not know whether due to the steroid or not, but he showed improvement after starting steroid. So we could take off the ventilator and everything, and he could discharge the patient. But still, the muscle weakness is still there. Only say one grade improvement for the lower limb muscles. So most likely what the thing is an Amman, a typical Amman variant, which is affecting only certain nerves in this patient.
Sir, MRI lumbar and sacral roots with contrast was done, sir.
No, it was not done. Because see why it was not done means, see the picture was not fitting with the radiculopathy. How can a radiculopathy produce weakness of the hamstrings with sparing of the plantar flexors and hip extensors? It just cannot explain. Muscle, okay, that's one possibility. Theoretically, that's a possibility. But acute involvement in this patient, 1 week.
Sir,
This
if
myopathy.
if it is not radical, hamstrings weakness can be explained by involvement of sciatic nerve, sir, here.
Yeah, but the problem is sciatic, the other muscles supplied by the sciatic is not affected. See, if hamstrings has to be affected, if hamstrings has to be affected, sciatic lesion has to be in the proximal part of the sciatic nerve. If that nerve is affected at that level, we expect the other muscles supplied by the tibial nerve and the conpinal should be affected. But they are totally spared.
Then how to explain hamstrings weakness, sir?
The only way to explain the branch of the branch from the sciatic nerve supplying the hamstrings is affected. Imagine what has happened is a tenth nerve involvement here. Palate is perfectly normal, no movement at all, no nasal irritation, but severe hoarseness of voice. And pharyngeal muscle also mildly weak.
MMNCB is possible here, sir.
Yeah, MMCB is the one which can present like that. It can affect patchy involvement of the nerves. Perfectly right. The problem is it's got a wasting diaper so fast in this patient. And of course, the nerve conduction is entirely normal, no conduction block. But you can argue that the muscles which has done that conduction block should have been examined. So what the mistake done, we did, I mean, the electrophysiology did was they did not do the femoral conduction. But even suppose the problem with the femoral conduction is that even if there is 50% weakness, the amplitude may come as normal. So we cannot be certain that this femoral is affected or not. If it is there, okay, well and good.
Sir, because the patient has pancreatitis, which is sort of a systemic disease, patchy muscular necrosis sort of thing.
Okay, you can that way think, but they think that that's going to affect that pharyngeal and laryngeal muscle with sparing also.
That's very odd. Like, yeah.
But if
That's
muscular necrosis is that CPK should be elevated, no, sir?
yeah, CPK was normal.
And painful also, usually.
Yeah. This is a very tricky case. That's not straightforward. And after when you examine second time, the thigh is definitely wasted. So it's definitely an axonopathy which has occurred. That only produces that rapid in wasting developing. See, I examined him 1 week after the onset of his weakness. Even at that time, there was suspicion of a wasting. Even though I was not sure because he was wearing a pant. But after then, when you examined subsequently, it was definitely wasting was there. Now, some of the Amman variant can remain like that without improvement for months and years. Okay, any questions? Further questions? Now, sometimes now you have to take a decision on your own. The road will improve. Some logical thinking you have to take a decision. Okay, shall we stop? We did 5 cases today. Or you want one more case?
One more case.
Okay, one more case. Okay, this it's again a short case. Those who study in the Kottayam Medical College will be knowing this case, so they can keep quiet. So, a 56-year-old man presented with numbness of the left little finger, which later on affected the left ring finger and the middle finger. This happened 6 months back. 2 months later, his right hand got affected the same numbness, but here it was confined to the right little and ring finger. That's his complaint. There was no weakness, no any other complaint. So this is you can hear the story of the patient, what he's telling. He is pointing out the numbness. These are the middle 3 fingers. First was the little finger. On the right side, middle, only 2 middle 2 fingers. Power was normal in the proximal muscles. Finger flexors are normal. Small muscles were normal. There is mild weakness of the long flexors of the middle 2 fingers on the left side. See, they can easily overcome the middle 2 fingers, but the other muscles we could not overcome. The pollicis longus, flexor pollicis brevis are all normal. Finger extensions were normal. Roman sign was negative. Reflexes, upper reflexes normally elicited. Triceps is normal. Left is also elicitable, but it's slightly less. Knee jacks were normal. Angle check normal. Plantar indefinite or flexor. See the sensory loss is telling it decrease on the little finger. It's also dulling in the little finger. The inside and outside there is equally set. The medial and lateral part of the ring finger was also equally affected, or not as equally spared. Vibration is normal in the little finger on the thumb. Joint sensors normal in the thumb. Okay. So on examination, gait was normal. Tone normal in both upper and lower limb. Power, mild weakness of interossei on the left side. Questionable weakness of the finger flexors of the medial two fingers on the left side. The rest of the muscles were normal. DTR, upper and lower limbs normal. Plantar flexor. Sensory impaired pain over both little fingers. There was no difference in the pain appreciation between the medial and lateral side of the little ring finger. Vibration normal in all the fingers. JPS normal in the thumbs. Gait normal. So, where is your localization and what you want to do?
Compressive cervical myelopathy.
Why not ulnar nerve involvement? What is evidence of cervical myelopathy? What is evidence of cervical myelopathy in this patient?
So bilateral involvement. So
Of sensory, you mean to say?
sense.
Why not ulnar nerve involvement bilaterally?
So there is no
Sensory
apparent flowing.
Well, like clawing may then it depends upon the which are the muscles affected. His predominant effect is sensory.
Non-meritus multiplex.
Okay, more is multiplex. Okay, good. Anything else? So from these findings, so difficult. There is one point against bilateral none. What is that point? He was complaining a numbness of the left middle finger also. But objectively, I could get only sensory loss in the little finger. But the middle finger, even though he said numbness, it was not their object examination. The object examination ring finger is also not. Okay. So bilateral ulnar nerve palsy, why not bilateral C8 radiculopathy? That's also possible. They can cause sensory loss in the ulnar nerve. Intramolar lesion of the CAD1, again possible. And none of them. These are the possibility. So what investigation you want now? NCS. NCS normal.
MRI cervical.
Okay. Now, before that, you see the what I examined. I purposely did not show this examination finding, which I always do. He is not able to appreciate the joints in the little finger on both sides. He does not know. So this is a cervical, as you said correctly, this is a cervical compression 4-5. Now the point what I'm trying is that anyone coming to with sensory loss in the immediate part of the fingers, bilaterally, it can be ulnar nerve, but always rule out a high cervical myelopathy. Because the first, before developing patient developing any paralysis or weakness, the sensory loss, the paresthesia may be only confined to the little finger. And the only sensory loss may be only for joint sense. In the vibration case, in this particular patient, vibration sense is normal. In fact, I did the joint sense earlier. I cut that part of the video to show it as a next video. Okay, so when you get numbness confined in the nerve context is normal, always rule out a high cervical myelopathy. This is hyperintensity in the cord there. If you take a contrast, you may be seeing that pancake appearance. This is a typical pancake appearance, and they do well with surgery. You may think compression may be so mild, but the hyperintensity within the cord and anthroposis like that. So, in fact, I again purposely not show one reflex. The finger flexion was brisk. Okay. These two I purposely not show. The reflex as brisk finger flexion as well as the impaired joint sense in this. Okay, any questions? I used to stress this point very often when I was teaching in Kottayam Medical. At all the pages there. Always when you get this thing, look for any joints and slots and confine the finger. Even if you don't check the joints in other fingers, check the little finger first. All of the fingers may be spared, only may be confined to the little finger. Why it is occurring in high cervical myopathy, I do not know, but this is the finding which I have consistently observed. Okay, any questions? Okay, then shall we stop?
Yes. Thank you, sir.
Thank you. Thank you. Good night.
Thank you, sir. Good night.
Good night.
Good
Good
night.
night.
Thank you very
Thank you,
much.
sir.
Thank you, sir. Thank you all. Thank you.
Good night, sir. Good night.
Good night, sir. Good night.
Good night.